Hello, everybody. Thank you so much for joining us today. Today, we are going to be presenting a webinar brought to you by the National Center for Health and Public Housing on the impact of public health emergencies on community mental health, preparation, and response. Before we begin, we are going to provide some background information about the National Center for Health and Public Housing. The mission of NCHPH is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. And the information presented today are those of the author only. This is just a kind of reminder for everybody who's joining us today that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions, any concerns, or any promising practices that you would like to share with us related to today's topic. Raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and recording link will be sent via email after today's presentation. And the chat has now been enabled for everybody. So here we have some, this is the information of the staff members that are going to be presenting today. My name is Fide Pineda Sandoval, and I am the Manager of Training Technical Assistance here at NCHPH. I will be helping and facilitating the webinar and moderating. We also have Dr. Kevin Lombardi, who is our Manager of Policy Research and Health Promotion. And we also have with us Tom Vu, who is the Executive Director and Chief of Corporate Compliance Risk Management for La Maestra Community Health Centers. Dr. Kevin Lombardi is a medical doctor and epidemiologist who currently serves as Manager of Health Research, Policy, and Promotion. His research focuses on a range of areas, including medical protocol, compliance, resource utilization, public health policy, and the social determinants of health. He has also organized multi-center clinical trials, designed studies to improve emergency department quality care, and utilized large institutional data sets to examine disparities in healthcare administration. Tom Vu serves as Executive Director and Chief of Corporate Compliance at La Maestra Community Health Centers. In this role, he leads operational aspects, including risk management, compliance, safety management, medical records, and partners with leadership across the business to foster innovation, support growth, and drive excellence. Tom brings a strong background of healthcare leadership, strategic insight, and diverse experiences to his role. Before we continue, we're going to provide some other information related to health centers that are close to public housing. According to 2022 UDS Health Center data, there were over 1,300 FQHCs that served to 30.5 million patients. 483 FQHCs were in or immediately accessible to public housing that served to 6.1 million patients, and 107 PHPCs that served to over 900,000 patients in 2022. Here we have some public housing demographics data. This data describes the demographics of residents of public housing. And as it is displayed, the 1.5 million residents demonstrates characteristics that differentiate them from the general US population. For example, residents of public housing are approximately 2 times more likely to be African American, 1.5 times more likely to be Latinx, and 1.5 times more likely to be children. Residents of public housing are also disproportionately from households that are low income and female-headed. And now we'll pass it on to Dr. Kevin Lombardi, who will kick off the rest of the presentation.
Hi, everyone. Thank you for your time today, and thank you very much for your service to your communities. So today, I'll be starting by setting the stage for Mr. Vu by going over some of the epidemiological and public health data that underlines this issue. We as providers have been under assault by public health emergencies for quite some time. The opioid epidemic, COVID-19 epidemic, local issues in our own communities at the same time. The burden of these emergencies and their impact on their patients has been increasingly severe. Now, I went through residency during COVID-19, and I found that I did much more behavioral health care than I would have expected. Behavioral health care has been a much larger part of my practice life, and much larger part of my work in this role as well. So I want to start by going over some epidemiological data on the use of services. And next slide, please. The rest of this session will be based on the grounding of the social determinants of health. For those of you who have an academic interest in the social determinants of health, I'd recommend taking a look at WHO conceptual framework. In this framework, the framework is part of a continuum based on our concept of universal human rights. The WHO framework encourages governments and institutions, including health centers, to further policy changes that lead to better health equity and outcomes through treatment of the whole person. Next, please. The SDOH will be baked into the rest of my lecture. And for those of you who would like some more information on it, we won't be able to go through much of the details of the social determinants of health and its impact on public housing residents today. But this document, in addition to being a presentation, also serves as a consulting document. All of the research and information I go over has links and details that you can bring back to your health center and share with your colleagues to help further your program and clinical needs at your institution. Next, please. Now, this might not come as a surprise for many of you, but we have experienced a surge in the demand for behavioral health and substance use resources over the past 10 years. This is due for a variety of reasons, but to focus on really what the data is telling us. The offices of mental health practitioners, except physicians, experienced an increase of 104% of their revenue from behavioral health between 2015 and 2021. Now, there are a couple of reasons for that, and this differs from community to community, but there are some main national trends that are driving this demand for behavioral health resources. Our patients, particularly those in public housing, have experienced the brunt of the opioid crisis. They've experienced disproportionately the impact of the COVID-19 crisis, and these have been primary drivers in the rise for the demand of mental health resources. Also, health centers have gotten very good at meeting patients where they are. The popularity of behavioral health telehealth services has also driven demand. Many of you have found innovative uses of your telehealth equipment over the last couple of years, and your patients have benefited significantly from that. And we'll go over some data in a moment showing really how those patients experience that. Next, please. For those of you who work in the clinic or who manage programs, you're likely acutely aware of the demand for behavioral health centers from your behavioral health services from your patients in the face of the emergency crises we have experienced in the last 10 years. But the crises have a similar effect on the workforce as well. Long-term emotional stress is a pervasive and serious consequence of high levels of exposure to crisis and low levels of access to mental health care. And this is the truth, not just for our patients, but for our workers as well. Current public health emergency response efforts provide inadequate support to behavioral health staff in many ways. And psychological care and social support in tandem are necessary to provide critical need and support to staff and community members. For those of you who are interested in reading a validated study about this, please click the link to the publication. Next, please. In the midst of behavioral health crisis, of multiple crises, both environmental and social in our communities, a disproportionate amount of our patients are experiencing the impact of, one, the psychological impact of COVID-19, but also the very real medical impact of long COVID. Long COVID is a phenomenon that is still not properly understood because it is so difficult to diagnose. But it's something we were gaining understanding of as the years go by. 1 in 13 adults have reported long COVID symptoms. Some of the symptoms that are most common are brain fog, cognitive dysfunction, memory loss. Some of you may have experienced this yourself in your acute COVID. Anxiety, new onset, and exacerbation of existing symptoms, and depression, either new onset of depression symptoms or exacerbation of existing symptoms. Next, please. The COVID-19 crisis has also deeply affected service delivery. For example, the share of adults reporting the onset of symptoms of generalized anxiety disorder or major depressive disorder rose to 39% during the pandemic. Lifting of restrictions led to 75% of behavioral health visits being via telehealth. And this has persisted since the end of the pandemic, with 87% post-pandemic. Also, the share of adults reporting the onset of symptoms of GAD, next slide. Now I'd like to go over a case study before we hand the mic to our guest. What I'd like to do is read the case study and pose some questions for our audience about this patient and about his experience in experiencing public health disasters. I'll read the study. Mr. Lee is a 68-year-old man who presents for his annual wellness exam. He has a past medical history significant of gastric reflux and hypertension. The patient also has a behavioral health history of major depressive disorder and generalized anxiety disorder, and opioid use disorder, in remission for 5 years. Mr. Lee prefers to use Mandarin Chinese for his appointment and is interviewed via a translation service. Your community has a large Chinese American population. The patient undergoes a standard intake, including vitals and an SDOH screener per facility protocol. Results are as follows. BP 128/78, heart rate 66, and a respiration 18. Those are all within normal limits for a patient of this age. You are the provider, and upon reviewing Mr. Lee's medical records, you see that he has previously received inpatient treatment for opioid use disorder in 2017 and severe depressive episode in 2019. His records also indicate that Mr. Lee immigrated from China in 2008 and that he works as a plumber in the community. Mr. Lee is married and has a history of opioid use disorder. His wife has a history of opioid use disorder as well. Their adult child passed as a result of severe COVID-19 infection in 2021. Documentation from past visits notes that Mr. Lee is often resistant to discuss his MDD and GAD. He is not taking any medications for these conditions. Next, please. Now, here's Mr. Lee's SDOH screener. SDOH screeners are a really good way to understand how various dynamics in the social determinants of health are affecting your patients. This is the WellRx screen, which is a validated tool. And for those of you who are interested, please click the resource. But let's go over how Mr. Lee filled this out. Mr. Lee notes that in the past 2 months, he has been eating smaller meals or skipping meals because he didn't have money for food. He notes that he's having trouble paying for his utilities. And he's having trouble finding or paying for a ride. Next, please. Mr. Lee is also concerned about someone in his home using drugs or alcohol, and that is his wife. Next, please. Now, to wrap up the case study, Mr. Lee's physical examination and lab results are all within normal limits. However, he is noted to exhibit closed body language and avoids eye contact. Upon questioning regarding his behavioral health history, Mr. Lee notes the following. He's not used opioids since 2018. Mr. Lee suspects that his wife continues to use opioids illicitly, but he's not sure. When asked about his MDD and GAD symptoms, Mr. Lee notes that he is fine and refuses to answer further questionings regarding this. When asked about his past behavioral health treatment, Mr. Lee states that he felt he could not connect with his past providers and that coming to the clinic for treatment makes him, quote unquote, uncomfortable. Next, please. Now, I'd like everyone to please take a moment to answer the following question. We'd like you to please put your answer in the chat, and we may ask you to share with us your answer. But what services or programs may encourage Mr. Lee to receive treatment for his behavioral health issues? And we'll take 2 minutes. And I'd like you all to please reflect on Mr. Lee and his experience. And at your health center, what services or programs would you encourage him to use? And I'll ask that during that 2 minutes, FIDE, if you could please cycle slowly through the case study so that our participants can see the details, please. And I see we have an incredibly diverse group of professionals joining us to hear from here. We'd love to hear what you think about Mr. Lee and how your health center would support this patient. I see some of our participants are catching on the cultural competency piece of this already. One of my favorite things about doing these sessions is the thoughtful responses that we get. Thank you all for that. So I'm going to take 20 seconds, and I'm going to ask my my co-hosts their perspective, and then I would go to the audience. And I'll start with you, FIDE. What do you think? If you could go to the question, please.
Yes.
What kind of services? Now, you spend a lot of time talking to health centers and talking to people about the programs that they have at their health centers around the country. What do you think? What programs have you heard that someone like Mr. Lee may benefit from?
I think most definitely referring them to a behavioral health professional who would take into consideration their cultural competence aspect of the treatment that would be provided to him, or any advice that could be given to him. That would be my take on this response.
Now, Mr. Wu, you work out in San Diego, and there's a large Chinese American population that lives in that city. I was wondering if you had any thoughts on the cultural competency piece that FIDE mentioned.
Yeah, I was going to say it's very interesting. The drug that's abused the most are opioids because they are the most prescribed. They have a high potential for abuse. So the pandemic really affected minority communities, Hispanics, Asians, African Americans, and that led to a lot more hospitalizations, triple the amount of hospitalizations. So these groups here, they reported more substance abuse as a way to cope with the pandemic, the COVID-19 pandemic. So these disparities, they're highlighted even more during an environmental crisis, where these communities have challenges due to limited access to healthcare, transportation, language barriers here. So again, it does show how important it is to address these inequalities in underprivileged areas. But It's also interesting to think about the reverse relationship, right? Patients with SUDS might be more vulnerable to COVID-19. So I was reading studies that have shown people with SUDS, a lot of times they have higher risk of respiratory and cardio complications. So especially COVID-19, it's a big threat to patients using opioids since it weakens the immune systems, and that leads to more hospitalizations in this group. So, and then the higher hospitalization rates, that lessens the health conditions even more, especially in communities that are already disappropriately impacted by COVID-19 and SUD. So for this, language, people with limited English skills, they struggle to communicate every day, and that seems like that's what's happening here. He may feel frustrated, intimidated, or isolated. So we try to interact with diverse communities, trying to bridge the language gaps, and that increases productivity as well. It improves efficiencies. We can comply with laws and regulations, and we want to understand everyone that we interact with. So no matter what language they speak.
Mr. Vu, it seems that some of our participants would agree with you, and thank you for those details. This is certainly a vulnerable patient from a vulnerable community that has experienced these emergencies disproportionately. FIDE, would you mind asking some of our respondents if they would like to share their perspective?
Sure, yeah. So I am going to unmute the line for Sarah Suitala. If you could please elaborate a little bit more on your response. I'm going to enable that right now.
May we call you Sarah? Yes, Sarah, are
Hello.
you?
Hi, can you hear me?
We can. Sarah, you have quite a thoughtful response here, and I thought that you may have and FIDE thought that you may have something to share with us.
Sure. So I work for the Colorado Rural Health Center now, but my background is as a school counselor of 18 years. So I am attuned to sort of serving diverse populations. I think in the case, in this case scenario with Mr. Lee, he is an older gentleman, and he has a background of being Chinese and preferring his services to be provided in Mandarin. And sometimes it's really difficult to find service providers in communities who speak the native language, but obviously that would be a preference. So if there is a way to support providers in becoming licensed and hired and supporting their retention, that seems like that would be an ideal scenario for Mr. Lee and probably other members of his community. So that's one barrier to sort of break down and hopefully increase his comfort level, because it sounds like he has been uncomfortable in the past. He suffered, a huge loss with his son dying, so there probably is some grief, and that can certainly exacerbate the major depressive disorder, the generalized anxiety disorder, and he should be really sort of supported in the fact that he did not relapse in the face of grief. So there is something to celebrate with him, even if he is still having difficulties. Also, it sounds like his wife would benefit from services. So some community resources would be wonderful for he and his family, because that sounds like that's something that's concerning him as well.
Thank you so much for those details, Sarah. And you said so much, but and you're joining us from a health center, am I correct?
Yes, I work for the Colorado Rural Health Center, which is the state office of rural health in the state of Colorado.
Now, do you folks have any programs or actions that you've taken to try to treat patients from diverse backgrounds that have had any success in the recent past?
Well, I'm very new to this organization, so I don't have too many details, but we are working on a grant through our state healthcare policy and financing group with rural healthcare providers to help them integrate their behavioral health services into primary care. So we are just starting to dive into that, and we will make sure that there are elements of cultural competency In the state of Colorado, our largest population are probably Latinos. And so language is really important to see if we can find providers who are native Spanish speakers or who have backgrounds in, Latin American countries. So that is something we do attend to when we're talking about integrating primary care, but really, workforce is such an issue. And so that's kind of the priority, is getting the workforce in place and supporting retention of the workforce so there's continuity in services, because that builds trust when people see the same providers over years and are getting consistent care.
I couldn't agree more, Sarah. And thank you for your service to your community, and thank you for making diversity and inclusion such a large part of your professional view of this, and your program view as well. I wish you luck with your grant.
Thank you so much. It's a privilege.
Thank you. Fide, would you pick one more of our participants to share their perspective, please?
Yep. Thank you, Sarah. Now I'm gonna unmute the line for Victoria Hall.
Ms. Hall, may we call you Victoria?
Hopefully she's able to participate.
Hi, can you all hear me?
We can. Could we call you Victoria?
Yes, Victoria is fine. Thank you. So with ours, fortunately here, I'm with San Bernardino County Department of Behavioral Health in California, Southern California. We are regionally one of the largest counties in North America. And so fortunately for us, we have a very diverse community within our county, different communities within our county. And so our Asian Pacific Islander population, we do have some communities where we have a strong API presence. Fortunately for us, our Office of Equity and Equity, oh, it's losing me, OEI, Cultural Competency Office, basically. Our program here offers several different collaboratives, subcommittees, and they're very engaging in the multi populations we have within our communities. And so our API presence, we're out there in the community, engaging our folks, getting them involved. So in this case, Mr. Lee, I would really get him into services to help him with the trauma he's been through, but really start engaging him into those communities where he could be with individuals that understand the culture, and just get involved in the community to help with some of that turnaround of what he's been through.
Thank you so much for your thoughtful response, Victoria. And you come from a particularly diverse part of the country. And it seems that when I speak to folks that work in areas like that, they tend to view the diversity in their communities as a strength. And it seems that you bring that perspective as well. So thank you so much for your service and for your comment. And we wish you the best.
Oh, no problem. Thank you.
And for those of you, if we do call you and you are not able to share or participate, that is just fine. So no pressure and no worries. So for time, we will need to go on. But thank you so much for your consideration of Mr. Lee. And we hope that when you have patients that are like Mr. Lee in the future, that you'll consider the conversations we had today. Next slide, please. And next, please. Now, I'm going to briefly go over a variety of resources that I've packed in here. As I mentioned, this document is meant to be a consulting document and to be a resource for you all to read and to use. But the use of SDOH screening tools is increasingly being used by organizations to provide to be able to understand the social supports required and needed by their populations. And as some of our speakers mentioned and our panelists mentioned as well, social supports of your population is an excellent way to both, 1, help them through the emergencies that they have experienced, and 2, to prepare them for the next ones that may come down the pipeline. One thing that I recommend for all of the health centers that I speak is to use an SDOH screener. They're a great way to understand your patients and what they need. Next, please. Now, in the case study, you can find a link to the WellRx screen. This is a recommendation that I have for where to put the screener. For those of you working in a primary care style system, putting a screener at the intake and in follow-up engagement is a great way to understand what your patients are need and to link them to the services that are available at your center. Next, please. And for those of you working in a inpatient style system, here's a recommendation of where to do the screeners as well. Next slide, please. Where you would put the screener. Next. Now, one thing that I would like to make very clear to everyone is that organizations, data has consistently showed us that organizations should alter their screeners, their SDOH screeners, to reflect the needs of their communities. Here's a link to a study that validates that. For those of you who use Prepare, those of you who use WellRx, add questions to your screener that relate to your community and your community's needs, in particular, their needs in an emergency situation. If you're in a rural area, add more questions about transportation needs. If you live in an area that serves a lot of residents of public housing, more questions about the specific social needs of that population. You may find it's a way to network people to programs more effectively and make the jobs of your social workers and CHWs easier. And I know we all appreciate the work that those folks do for us. Next, please. Another article to validate action for those of you who do use SDOH screeners and would like to change them. And for those of you who don't, I strongly recommend making an SDOH screener part of your standardized patient intake and processing. Now, Fide, we won't have time to go through the research I provided, but if you could just go to the first slide of that, so I can explain it to our guests. It's a couple down. Yes. So from this on, I provide some research that my team provided on the use of mental health services and telehealth services for patients and FQHCs, and some recommendations on marketing telehealth services to behavioral health services to individuals in public housing and FQHC's patients. And with that, I will leave all of that data for you to review, all to use as an extra resource at your convenience if you see fit. And I will cede the floor to our colleague, Mr. Vu. And Fide, if you could please go to the beginning of his slides. Throwing you the football, Tom.
All right. Hi, everyone. Thank you for having me today again. I'm Tom Vu. I serve as Executive Director for La Maestra Community Health Centers, with operations including risk management, compliance, patient care, and safety. I'm glad we're having this discussion today on how public health emergencies impact both mental health of our community members and our health center staff. So I'm happy to share some of the strategies we've developed, which might help other health centers with similar issues. Next slide, please, Fabian. A brief overview of our operations for some insight on how we strategize for emergency preparedness. We serve in many different communities, diverse communities, with some of the biggest medical and economic needs in San Diego. A large percentage are low income, immigrants, refugees who prefer to be served in a language other than English. We also provide a wide range of support services that go beyond the primary health care, like education, outreach, job training, transportation, housing assistance, and food. So we play a big role in the safety of the communities. We become the support system for our patients. We expect that they're going to come to us for triage, for information, and in some cases, shelter. So Our patient demographic includes patients with chronic disease, mental and behavioral illnesses, anxiety, depression. So we try to integrate all of this into our emergency preparedness planning. Next slide, please. So during the pandemic, the COVID-19 pandemic, patients are dealing with anxiety, fear, depression, and for underserved communities like ours, it's especially more pronounced. There were barriers to healthcare information, access to care, and that adds to the mental health challenges, especially in the beginning of the pandemic with social distancing and quarantine. Patients are dealing with isolation, loneliness, hardship, economic hardship. So that affected how we delivered behavioral health and addiction care. Patients had fewer options for treatment and support. With natural disasters like wildfires, earthquakes, and extreme temperatures, that leads to trauma, just like all other public health emergencies. And when you're displaced, if you lose your home, our communities are in areas that are more prone to these types of disasters, and that adds to the impact, and that can trigger PTSD, anxiety, and depression. So the disruption of services, especially during emergencies, it directly affects access to behavioral health and addiction services. With IT disruptions, it affects communication, that affects access to information and essential services. That leads to feelings of hopelessness, anxiety, again, isolation. It's especially challenging for underserved communities who rely on these services for their basic needs. They won't have access to care, telehealth services, which actually became vital during the COVID-19 pandemic. And then it hinders behavioral health and addiction care for patients who really need it. And then we plan for utility outages, so communications, water, gas, disruptions in service, which creates a lot of stressors and challenges, and that magnifies the mental health issues and it affects access to care. It causes immediate stress and anxiety. You don't know when these services are going to be restored. People worry about their safety, access to information, and the ability to contact their families during communication outages. It affects mental health directly. Outages can isolate people more, especially when they rely on technology to stay connected. And isolation and loneliness, that contributes to depression and anxiety when you can't reach out to your support networks because it's detrimental and because the patients lose that emotional support. Next slide, please. So during the pandemic, we saw a mix of things that we know increased drug use. People are stressed and isolated, so they make unhealthy decisions, including drinking and taking drugs. And these are some of the impacts: anxiety, suicide prevention, patients with chronic conditions, substance use. And the trend, it's been substantiated by data that shows that there's an increase in these types of behaviors, especially during the beginning surge of COVID-19. So it brings up concerns about ongoing mental health and substance abuse now that we're moving past the pandemic. 97% of our health center patients qualify for public housing assistance. People and their families go through financial strain during public health emergencies because they lose their job or they have less income, they have more healthcare expenses. So the financial strain can make it challenging for them to afford safe and stable housing. Patients will find it difficult to keep stable housing arrangements or going through eviction because they can't pay their rent or mortgage payments. So we provide housing and social services, and we connect eligible patients with public housing programs as well. We'll collaborate to address both the mental health and the housing needs of our community members. Next slide, please. Like I said, patients, they rely on us as a support network, especially in times of uncertainty. We become more than just healthcare providers. We're a central hub of information and resources for our patients. They trust that we'll keep them informed about situations, whether they pertain to their health or external events that can impact their well-being. So at the heart of our approach, we place an emphasis on community-based outreach. We have a dedicated team of medically trained cultural liaisons who play a huge role in bridging the gap. They're not just staff members, they're ambassadors within their respective communities, and they're trusted. They have a combination of medical expertise and then the deep-rooted cultural understanding so they can integrate communities into preparedness activities. We hire them from within our local community so we know that they have not just an understanding, but they have an innate understanding of the cultural values and the nuances that influence decisions. So that lets us create a more patient and culturally diverse, sensitive healthcare environment. And then before the pandemic hit, we had invested in the telehealth infrastructure. So when DHCS rolled out flexibilities for telehealth services, it allowed us to adapt to the changing landscape so we could provide uninterrupted and safe access to medical care for patients. And this was really big, not only with continuing the essential services for medical care, it was big for during the pandemic, for the patient's well-being during the pandemic, during the PHE. So during this time, California implemented a lot of policy flexibilities to kind of adapt to the PHE, like they expanded the telehealth services, so getting equal payment for telehealth services as for in-person services. There's more flexibility with using non-HIPAA compliant methods like regular telephones or video chats. Those were lifted, and that gave us more flexibility in how telehealth services were provided. So services for mental health and SUDS treatment were expanded to allow medicated assisted therapy to be delivered via telehealth. And patients have really embraced that, as we move past the pandemic. They're proposing to make these flexibilities permanent, like the payment parity and coverage for audio-only telehealth services like telephone calls. Again, with cultural competence, underserved communities, they often have a disproportionate burden during the PHEs, the public health emergencies. So there are cultural factors that we pay attention to. Cultural beliefs, stigma, and language barriers can be a challenge with addressing mental health and addiction issues. So health center staff, they receive training in cultural competence to understand and respect the cultural values and beliefs and practices of the underserved population. So we collaborate with community members, community leaders, and organizations and use cultural competency strategies to make sure services are accessible and that they're respectful and effective to support mental health and behavioral health needs of our diverse populations. And then policy intervention, so to lessen the impact of the PHE on community mental health, I think interventions could include policies that increase access of mental health services like the telepsychiatry, mobile health units, continuing with the telehealth flexibilities that we've had, expanding them to make sure that patients can access mental health and addiction care remotely. I know administration has proposed making some of these flexibilities permanent, which is great. Policies that protect against evictions and utility shutoffs that can reduce mental health burdens. Economic relief measures like the direct cash assistance and extended unemployment benefits that can alleviate financial stress, and policies that can give priority to addiction treatment as an essential service, so that can help people continue to access treatment and support during emergencies. We need interventions that help out, give resources, make it easier to get care so we can mitigate these impacts and look after the well-being of our communities during and after these emergencies. I think the policies should focus on the immediate and the long-term plans for mental health and addiction care, especially for people who don't get enough support. Next slide, please. We have 65 plus languages and dialects at the community level. Patients that are limited in English can be difficult to reach, so we provide a number of translated materials and links to websites. We combine communication with local organizations to send out information to build visibility and really build trust. Face-to-face conversations work really well for us, especially in safety-sensitive situations. Again, our cultural liaisons are facilitators from the many cultural backgrounds we serve, so we can be flexible when we're talking about the health or safety concerns that are changing. They're always changing. We try to not only have these resources established, but have them readily available to our patients. So accessibility really is at the core of our approach, helping patients connect with our healthcare services whenever they need help. We try to figure out the best form of communication, like telephone calls, text messaging, emails, even direct door-to-door contact within our communities. People who are deaf or hard of hearing may not have access to information. People who are blind or who have low vision aren't able to use written information. So we try to combine visual and audio reach to more people. We have closed captioning on our televisions in our health centers. We have staff that are qualified in sign language, interpreters remotely via telephone, smartphones. The health plans that we contract with can dispatch sign language interpreters. We have third-party language line, which we contract with to provide video remote interpreting services. And this can be done on a tablet, smartphone, or a laptop. So non-English speakers, as well as deaf and hard of hearing, can be seen and heard. Next slide, please. Our call center is typically used for administrative purposes like scheduling appointments. So during a public health emergency, we can coordinate our call center specifically for emergencies, for outbound calls and incoming calls. The call center telephone line can be established for triage, where people can get up-to-date emergency instructions and they can get guidance in different languages. Having our call center really improves how we can provide information and make sure that it's on time, it's up to date, it's consistent, accessible, so that during emergencies, it's a big undertaking. I'm trying to reach so many patients. So we use a texting service called Well Health, and that gives us the ability to text all of our patients, all at the same time with broadcast messages. So how it looks is, it says, hello patient, this is Tom with La Maestra. Due to the pandemic or due to the wildfires, your appointment has been moved to our national city site, for example, and here's the address. And then the patient can confirm yes or no. The texts have pre-written responses for different scenarios and questions. So it's bi-directional texting, which has been really great at keeping patients informed. Next slide, please. And then we secured, just talk about really briefly, emergency backup generators. This has been important to keep electricity going for the entire building in order to continue patient care. So, clinics are so dependent on the electrical grid to provide services. The question is always, how do we respond to power outages so we can continue care for patients and be self-sufficient? And for years, we've always had the challenge of continuing operations during an unplanned power outage or even a planned power outage. We have small generators for powering some of the refrigerators for vaccines and some lights, but we really needed a large amount of power to keep moving. So it really is the most important piece of equipment for large scale emergencies. The generator automatically turns on and provides electricity to systems and operations as soon as we lose power from the main grid. We perform regular testing in the batteries and hiring qualified personnel to repair and maintain generators. So that's been a blessing. In the case of disruption of service, our organization is also registered as what's called an essential user, meaning that the health center is on a priority list to have services restored during a blackout. And that's been really important for us. As health centers, we are on a priority list and we provide vital services, especially during the summer months here in California, where we are prone to heat waves and fires. We have to know that our services will be restored during a blackout. So I would suggest, if you can, to be listed as an essential user with your public utilities company. Next slide, please. As another resource, we are contracted with ChartGuard. It's a company it's a business continuity solution for continuing patient care. ChartGuard is a third-party software. It creates PDF copies of our patients' electronic charts for upcoming appointments, along with a copy of the appointment book and the patient's last 3 visits. And then it stores them at each of our health center locations. So during a disruption, public health emergency, these PDFs, they can be printed and viewed on laptops we have that are dedicated for emergency preparedness. And we prefer this because it integrates with our EHR system. It's up to date with the appointment schedules and patient charts every night. It constantly updates, so we can customize the information we want to see in the charts, in the demographics, allergies, medications, and lab results, so that during an interruption, our providers have the information they need to continue care. And for us, this has been a big component of our continuity requirements under HIPAA security rules. It provides access to clinical information when we don't have power during a system or network outage. Next slide, please. Peter, if you could move on to the next slide, I can continue if you're having a, oh, there it is. It might be on my end, it might be an internet connection on my end, it's not showing. There it is. We do collaborate with the San Diego County of Emergency Services to have La Maestra listed as a point of distribution. It's a POD during a disaster, meaning we can have stockpiles of medications or vaccines delivered to us, and it's up to 1,000 doses per hour. So within 48 hours, we get these medications to help protect San Diego County residents. So instead of storing medications, there's really nothing to do on our part. It's just having the medications in our sort of back pocket. So for example, currently the County of San Diego has stockpiles of doxycycline and ciprofloxacin. So in times where this has become necessary, the CDC ships the medication to the San Diego County, and the county distributes the medications to us as a pod, POD. And this is done through the Strategic National Stockpile Program. I always recommend to health centers to try to enlist as a POD, a point of dispensing, because this would be a great way to respond with medications during a public health emergency. Next slide, please. And then actually, if you could just, well, yeah, this is fine. I'll jump to cybersecurity. Cybersecurity, it's a big priority in our safety planning with healthcare. In general, we're seeing an increase in breaches and ransomware because of all the PHI, protected health information, that we have. Our IT department keeps layers of security protection, firewall, which protects our network from the outside, and then proxy internet servers, which protects our network from the inside. This is super important. Our security software stays updated on all of our servers. Any staff who work remotely, they are required to use VMware to log in, and that protects us from having our systems shut down due to an emergency. That keeps our viruses from transferring from the personal computers to the company server. Our IT department backs up this data in the event that it gets stolen or there's a disruption in service. So this falls under our IT contingency plans. We can access a backup copy of things like patient billings, lab tests, patient information. So if there's a failure, we can rely on backup data. And then our cyber insurance carrier conducts risk assessments and scans our network to detect any open RDP ports, and then they send us reports based on new findings in our network exposure. Again, this is super important for us. Our IT department can fix any misconfigurations and lets us know if there's a low, medium, or high risk. So this has been a high priority for us, especially with cyber threats. There, can trigger these emergencies that impact patient care and public health. So cybersecurity is an ongoing process. It's constantly maintained and monitored. So we're always looking at our security environment. Next slide, please. And collaborations, we have community resources when we plan for emergencies and public health information, and this includes working with the city, county, and regional planning. So locally, we create agreements, MOU agreements with local supermarkets and stores to provide water during emergency, and then agreement with the gas station to provide fuel, diesel, for example, specifically for backup generators. So we work closely with the police department, local fire department, our public utilities, San Diego County Office of Emergency Services, the San Diego Food Bank, the County of San Diego Health and Human Services Agency, and then we partner also with local school-based sites. Next slide, please.
And then Tom, just to make sure that we keep track of time, we do have 2 questions already in. I don't know if you would like to respond right now, or do you want to wait until the end of the presentation?
I just have one more slide. Maybe I can cover that one.
Okay.
Yep. I'll try to get through this really quick. It should be. Safety incidents. So lastly, as part of our risk management program, we review these dashboards. It helps us look at benchmarks and compare them to previous years. So these are our safety incidents and near misses. It's really important for us to kind of trend the incidents that are happening throughout the health center, and then we can make decisions. Here going left to right, you can see that there had been a year-on-year decline in complaints. And I wanted to share this with you because, you know, until 2020, we start to move back up as far as the amount of incidents through 2021 on the right. Of course, the pandemic, which we're talking about, the PHE, has shaped a lot of the patient complaints because from the patient's perspective, you know, their experience changed almost overnight, where a patient could normally drop in about an issue. All of a sudden, we had to deal with masks and PPE and infection control and screening patients before they can enter. And, you know, we couldn't always accommodate all family members into the clinic at the same time. So many of these grievances, they weren't related directly to COVID-19 itself, but a lot of times they're about how care for other conditions were delivered due to the changes from the pandemic. So the most common complaints were delays in treatment, wait time for treatment, communication issues, flexibility with appointments that want, you know, face-to-face during the pandemic, or it's the face covering policy. So it really is like shining a light on where things might not be going as planned. And then next slide, please. It's really it.
All right. Well,
Yes,
thank you.
that's it. Yeah. So yep, that's it. I'm just happy to share some strategies. Thank you.
Fide, you mentioned we had some questions for Mr. Vu. Is that correct?
Yes. Yep. We do have 3 questions from the audience. I do want to let everybody know that I know we're right almost at the hour. You're more than welcome to stay on the line. We are going to continue responding to all the questions and just give a brief, just go over some announcements at the end. All right, so for the first question, we have what staff members participated in door-to-door outreach and monitoring during emergencies?
It's definitely our cultural liaisons. They're medically trained. They have a big role in how we communicate with our communities. They're trained upon hire annually thereafter. Like I said, they're from the communities we serve. And they're always, you know, they're pounding the pavement. That and our outreach team does communications at fairs throughout San Diego. So we really take advantage of our medically trained cultural liaisons. And then, like I said, telehealth has been really big as well, especially during the pandemic. Big since COVID-19, you know, it's a virus that spreads through droplets. So we've taken precautions to kind of, I'm talking about during the pandemic, you know, we were in close quarters, especially we had close in-person sessions that meant sitting in a small room. It didn't meet CDC recommendations to socially distance. So that led to the temporary shutdown. And a lot of that had to do with the telehealth being big for us as well.
Great, thank you. And then for our next question, we have during emergencies, do you augment your staff, particularly your mental health or social work staff during emergencies? If so, please provide any details.
Our staff are trained. We have our training annually. And like I said, we have our training quarterly on how to manage these emergency situations. And we're always asking, you know, we're talking about public health emergencies and substance use. Why are our communities turning to substance use as a way to cope during the pandemic? So our staff is trained on not just addressing these challenges that have kept the community from having their needs, but, you know, the closures have affected us as well. the overall lack of access to care in our communities, our disadvantaged communities. So that's been a major reason of poor outcomes, and then relying on the self-medication that we were talking about earlier. So that has led to substance abuse, and that's where we get training. And this is where, like I said before, SAMHSA could play an important role, investing in these programs that increase access to treatment for future pandemics and to lessen the disparities during these public health emergencies.
Perfect. Thank you so much. I think that also kind of answers the other questions that we have, and the cultural liaisons have mental health training.
Yeah, and one more thing, it's training for healthcare workers too. It's providing more training and resources to support the healthcare workers and their mental health. One of the most common complaints is the wait times, like I said. So a strategy to kind of manage the increase in demand is to include a closer relationship with liaisons between mental health providers and the PCPs to improve mental health integration. So it's giving the employees a voice in their work conditions, and designing work schedules to kind of reduce the stress, cultivating leaders and values, and that encourages healthy supervision and respect for the workers. So surveys to kind of track the mental health of our healthcare workers, the stress levels can be that can be done at every organization to monitor the impact of the workload and the burnout of the workforce, especially during the public health emergency. That was really big too.
Well, thank you so much, Tom. And those are all the questions for now. And if you have any follow-up questions, you can also always contact us via email. So this is now the end of our Q&A session. Kevin, do you have anything else that you would like to
Yes, I'd just like to briefly thank our speaker, Mr. Vu, for sharing his programs and perspective on this very important topic, and to thank all of our participants for their service to their communities and for their time today.
This is just a kind reminder to everybody to please complete our post-evaluation survey, which will be provided to you right after the end of the webinar.
We do take those responses very seriously, folks. So thank you.
Yes, we do. Thank you. So we really appreciate your honest feedback, because that will also help us make any improvements for future training technical assistance activities. So here, if you would like to access our other resources, you can also visit our website at nchph.org. And here is our direct contact information. If you would like to contact Dr. Kevin Lombardi, kevin@namgt.com, or me at fide@namgt.com. And the contact information for Tom Vu will be provided in the slides as well. And thank you everyone for joining us today. Have a wonderful day.
Thank you, everyone. Bye-bye.